this is the benefits. If you look at the benefits of statins over time, so most of the trials of statins are just a few years long, but actually if you look in the meta-analysis, it actually the statin effect does actually increase over time. So the risk reduction in the first year is about 0.88, and then 0.73, and if you look at the genetic studies, actually the PCSK9 receptors, the people who have lifelong lower LDL cholesterols have substantially lower cardiovascular risk than you can achieve by getting the cholesterol down to the same level on a drug. So I think that there is probably some cumulative favourable effect over time of being on the drugs for a while. And in terms of explaining to the patient, I think it's incredibly important. It's not just, you can't just take a statin when you feel like it for a few weeks and then say, oh no, I'm just going to have a holiday for a moment. Well, you can have a holiday and then go back on it, but basically the benefits come from getting the LDL cholesterol down and keeping it down over a period of time. That I believe is the case. And then the benefits go away. Actually, there's a lag effect, so you get it takes at least 2 years after you stop if you've been on a statin for a few years in the trials, there was a lag effect of a while after stopping the statin before the events caught up again.
I remember being told there was an increased incidence of coronary event immediately after stopping.
Yeah, that's a bit controversial. I think that was actually, there was a study in Dunedin about that a number of years ago. It's theoretically, it's a very nice, interesting idea, isn't it? I don't know if that's actually robust information though.
It's also true with aspirin, apparently, stopping aspirin suddenly.
Aspirin makes much more sense because you've got a much more immediate thing, and I think stopping anticoagulants is another area where we know that you actually, the process of, but that makes, it's much, when we understand what's happening, it makes much more sense that you've got an antiplatelet drug or an anticoagulant and you suddenly stop it, then that's going to change the coagulation and the risk might be higher. And I think, and anticoagulants is the same. If you suddenly stop them, the risk becomes higher. There's a kind of a little bit of a rebound effect after you stop it. But but statins, I think, are working in a different way. They're not just having an immediate effect. They might have some immediate effect on LDL function, but I think the primary effect is to get rid of the atherosclerotic, the lipid-laden plaque in the arteries, and that takes time.
But I think Peter Rothwell from Oxford suggests actually reducing coming off aspirin slowly if you are going to stop it. Yeah. There's a podcast, a BBC podcast.
Right, okay. I didn't
just talking about that.
Right.
It was the first I'd heard of it actually. Right. Increase the MI after stopping aspirin.
Right, right. These are my points I was going to make. So understanding the disease process, I think, and then trying to explain that to patients. I mean, in rehab, I think the challenge of recognising the symptoms, what are the symptoms of cardiac disease and what aren't, and I think that's a real challenge, isn't it? It's a very fine balance between, on the one hand, just reassuring people and saying you're going to be fine, which is actually what I tend to do. I say, you take the medication, you're going to be fine, because statistically, actually, most people, the chance of a recurrent event in the next year is actually only a few percent. And the amount of worry, the amount of time we have people, they come in and then they come in with recurrent chest pain and things. It's almost always not cardiac. So, but on the other hand, you don't want them to ignore symptoms when they're there. So that's distinguishing stable from unstable coronary disease, I think, is incredibly important in a practical sense. Unstable, that's where the trouble happens. And then we've discussed those other things. Okay, so here are some ECGs. I'm not sure whether, what do you think this ECG shows? Okay, so inferior STEMI. So what people are saying is that if you look here, the inferior leads are 2, 3 in AVF. And you see that the ST segments are up about, significantly up. And then you see here there's this down before up is the Q wave. So that Q waves happen when so the ST segment goes up. If you block the artery off completely, there's no blood going to that bit of the muscle. So that's transmural myocardial ischemia, and when you get transmural myocardial ischemia, the ST segments go up. So if you get subendocardial ischemia, so there's just That typically happens in a narrowing of the artery, or there's some collateral supply providing an alternative route to that bit of the heart. Often you get ST segment depression. So that's why ST elevation is the thing that triggers us to say we've got to do something to unblock the artery, because it's the ECG change of a complete blockage in the artery. Now, if we look at the Q waves, we'll say we can tell how long the infarct has been going on. You can ask the patient, of course, but if you don't want to talk to the patient, you can look at the Q wave, and that shows that that's the myocyte necrosis. So the QRS complex is a depolarization of the muscle, and once it's dead, it doesn't depolarize. So if it's alive, it depolarizes, even if it's ischemic. If it's dead, it doesn't. And then, so the Q wave is actually the loss of the anterior directed forces towards that bit of the ECG. So you're actually seeing the uncompensated forces going the other way, which gives you the Q wave. So the bigger the Q wave, the more muscle, the more time is combined, the more muscle is dead. So you can say, in this person, there's plenty of muscle. They've got a big R wave and a little Q wave, so there's plenty of muscle to go. And you can see here out on V5, V6, there's the ST segments are up, so that means it's not just the inferior wall, it's the lateral wall around here as well. So that, what might that suggest? So that probably big right artery, so nine times that, so you can almost certainly, well, probably the right artery, but there's a posterolateral branch that supplies infralateral left ventricle wall, but it's a big territory, anyway you can say that, and you can see ST segment depression here, which is the reverse of ST elevation, and the inferior leads is ST depression when you're looking at it from the other side of the heart. So that's an acute inferior infarct, STEMI. So if that ECG is a reason to not pass go straight to the hospital, ring them up and tell them to get the cath lab organised, or give the thrombolytic drug if you're in a situation. So the thrombolytic drug dissolves the blood clot from the artery to, and it's about 60 to 70% effective. Taking to the cath lab and putting a stent in, opening up pushing the clot out of the way and putting a stent in is kind of 98% effective. So that's inferior.
Do you stent non-STEMIs or just the STEMIs?
No, we do stent non-STEMI, so we do stent every non-STEMI, but the time frame is different. So STEMIs, in this situation, the ECG is telling us that the artery is blocked. And the artery is blocked, there's no blood getting down to that inferior wall, because there's ST elevation is saying transmural myocardial ischemia. And the longer the time goes by before the arteries open up, the more muscle dies. And so the strategy is you want to open that artery as quickly as you can. So that's why all our systems of care are designed to, how can we reduce the delay time to which that happens? So we have indicators that say that it should be 90 minutes from when you get called until when you open the artery. And we have a whole systems of care related to diverting the ambulance. So before, the ambulance used to go to the nearest hospital, but now it goes to the hospital where they can do the PCI. And if you're going to be more than an hour and a half to get to more than 90 minutes, if that can't be achieved, then you should give the thrombolytic drug, and that should be happening ideally in the ambulance, but as soon as you can, but ideally in the ambulance. So that ECG was enough to say that you do one of those two things. So if you can get the patient to the cath lab within 90 minutes, you do it. And so that means we used to say, well, if they were in the Middlemore area, they'd go to Middlemore, and then somebody would look at the ECG and think about it, and then they'd put them back in the ambulance and take them to Auckland. So that lost an hour, and then, and they used to say, well, go and see your GP first, and that lost an hour. So try to cut out all that middle stuff and just straight to the thing, if that ECG is the case. Now, so that's ST elevation, and then there's an example of what might have caused that. So this is the catheter there, and then the sudden blockage of the artery at the top there is by blood clot. And that's incredibly easy to open up with a wire. So the wire just goes straight across the blood, because it's all just really soft, and the wire just goes straight across, and then you just push the balloon across, and then suddenly the blood flows down. So normally, from a PCI point of view, they're actually quite easy to do, and then you put a stent in, and that's made a big difference, because you stop the myocyte necrosis, and all the outcome depends on the outcome after an infarct largely depends on how much muscle you've lost. So how, and therefore what your ejection fraction is or your cardiac function is after the heart attack. So the worse, the more you can limit that, the more everything else is better.
Does your ECG change straight away?
Yeah, so the ECG will go, well, if you blow the balloon up in the artery, the ST segments will go up in about 20 seconds, 30 seconds, and then you let the balloon down and the ST segments will go pretty well straight down again. But in this case, it depends on what's the injury to the muscle further down. So you get and that actually that tracks with prognosis. So if you open the artery up, the best thing to happen is the ST segments come straight down, and that's great. And about a third of the time, there's what we call persistent ST elevation. So the artery's open, but the blood's not getting to the muscle, and that's probably due to microvascular ischemia and poor blood flow peripherally, and the ST segments don't come down. And in that case, well, they often slowly come or down or gradually come down, and the LV function takes a hit there. And there was a practice of sucking the blood clot off, because it was thought that all the blood clot that is in the artery going down the artery must be bad. They must trash all the small vessels and be bad. But there's a very large study that showed that even though it's a very nice idea, it doesn't make any difference. So you just push it, yeah. So then you've got, so that's STEMI. The abbreviation everybody calls is STEMI, which is ST elevation myocardial infarction. So that's one category. And then left bundle branch block. So with left bundle branch block on the ECG, you get the activation of the ECG is basically what left bundle branch block is. It masks the ECG from everything else, so you can't see what's happening. So that's traditionally been treated in the same way as STEMI. But actually, whether that's right or not is a good question. So left bundle branch block is normally regarded as STEMI. Now, if the ST segments aren't up, so this is non-STEMI, it's basically everything else. So if you've had an acute coronary syndrome, and that includes a normal ECG, T-wave inversion, ST segment depression, that's all non-STEMI. And in that situation, typically, it's not so critically time dependent. So in a typical patient with a STEMI, non-STEMI, doesn't necessarily have ongoing ischemic pain when we see them. So they have an episode of ischemic pain and then it goes away, and then it might come back here and then it goes away. And usually when you do the angiogram and you look at the artery is narrowed, but it's not blocked. So there's some blood going down, and that's causing myocardial ischemia, but it's not causing transmural myocardial ischemia. And the troponins up, so there's been some myocyte necrosis, but it's not necessarily ongoing myocyte necrosis. So in that situation, the speed at which we do things depends a bit on the patient. So if they've obviously got ongoing chest pain, the ECG changes, then we treat it the same way as you do a STEMI. But very often with a non-STEMI, that's not the case. So that's the person who's come in, they've had chest pain yesterday, but by the time you see them, they're fine. But the ECG shows one of these changes, or the troponin's up, they've got an unstable lesion. The concern is they're not actually getting myocyte necrosis now, but they might get it again because the artery might narrow or block off. And those patients generally get a stent as well, or at least 60 to 70% do, because when you do the angiogram and you can find the trouble, if it's in a major artery, you put a stent in to deal with it. If you can't find the narrowing, then you might manage it medically. So there'll be a proportion of people who are managed medically. It does depend on the anatomy. So non-STEMI is managed in pretty much the same way, except that you don't have the immediate sort of urgency of the time. The rates of STEMIs have fallen precipitously, and one of the things, probably almost certainly one reason that is smoking. So smoking causes blood clot, basically. So smoking seems to be a major driver for STEMIs. So I think that smoking rate, in fact, they introduced there was a clear temporal relationship in Italy where everybody smokes, and they introduced some ban on smoking. I can't remember exactly the nature of the ban, but there was a population decrease in smoking, and almost straight away the rate of STEMIs went down. Non-STEMIs are much more rated to sort of, they're much more rated, tend to be diffuse disease, and other risk factors are much more important, and they're going down as well. They're actually declining quite significantly as well, but not as fast as STEMIs. So we see actually more non-STEMIs than STEMIs now. Yeah, and interestingly, the risk of recurrent events is actually higher in non-STEMIs than STEMIs, because often a STEMI happens, when you've got a sudden blockage of the artery, but non-STEMIs happen in people who have much more diffuse. Well, it's an exaggeration, but often those people have much more diffuse vascular disease with more lesions that are more likely to cause more trouble. So the non-STEMIs actually have a higher recurrent event rate than the STEMIs. But the STEMI, because of the nature of the MI, they often have worse, it's more likely to affect the LV function because it's causing them, more myocyte necrosis at the time of the event. So it's the STEMIs that tend to have the bigger heart attacks and the worse LV function afterwards. Okay, so we have here a 45-year-old man who's got, okay, so he's got crushing retrosternal chest discomfort of modest intensity, radiating up to the neck or jaw and associated with mild left arm discomfort. So I guess actually a couple of things about the description of the chest discomfort. So often, we're often misled if you say to somebody, "Have you had any chest pain?" They'll say no, and some people just that'll be the end of the conversation. So often, the wording has to be, "Have you had any sensation in the chest?" or just have you had a feeling in the chest? And often, well, crushing, I guess, is the typical kind of description of cardiac pain, but a localized or jabbing pain would be relatively unusual. And then the radiation, as people know, we're talking about a visceral pain, so it's relatively poorly located, but may often be felt in the neck or the left arm. But that doesn't necessarily mean it's cardiac. Any pain, visceral pain might be in that distribution. So some shortness of breath. So I think shortness of breath, actually, that's a bit of a red flag to me. If somebody gets chest discomfort and they're short of breath, then you've got to raise, is that cardiac or cardiorespiratory? You don't just ignore it if they say they're short of breath. Lasted for 15 to 20 minutes, so that would be typical. So it's discomfort that lasts like seconds only or all day without changing. That would be relatively unusual, or 3 days. Okay, then he went back to sleep. So if that, with that history, obviously that history is very suggestive of a cardiac episode. Now, if you saw that person 2 or 3 days later, I don't think you'd just want to ignore it like he's feeling perfectly fine now. But that's what I mean by, could this be, could he have had an unstable coronary event? So, I think you want to do an ECG at a troponin level by then. Anyway, he has further episode when he has breakfast brief and then a couple more episodes. And the key thing is it's happening like there's no particular kind of pattern to it. So if you had a fixed narrowing of the artery, you'd expect it to be more predictable in the way it's happening, but this is happening in no particular way. But that doesn't necessarily mean it's not cardiac, because if it's an unstable acute coronary event. Okay, so he's got dyslipidemia, smoking, so he's got risk factors which increase. So here's the ECG, and okay, well I think let's for argument's sake, I think it's normal. Can't see any obvious change. So the key point here is the fact that ECG is normal does not mean you haven't got a problem. Okay, so here's the routine bloods, and the troponin actually interestingly is 12. And that's just slightly below the normal range. But actually, the normal range of 14, 12 for a 45-year-old man, it's kind of slightly on the high side, actually. But nevertheless, you'd say, oh, that's fine. But he actually has a repeat troponin several hours later. I'm not sure how, and it goes up to 20. Now, if you had an 80-year-old, you wouldn't be too surprised to see somebody with a troponin 20. But in a 45-year-old, and it's gone from 12 to 20. So even that small change, so it's a more than 50% change, that is, with a high sensitivity assay, that is clinically important. So what you say is that there has been some cardiac injury. He's had recent chest pain and he's had some cardiac injury, because that troponin actually has changed, and you've got to have a high suspicion that that's a coronary event, even though the absolute measures don't look very much, and the ECG is normal. And it turned out, I don't know whether this is him or not, but anyway, here's an example of what it could be. So here's the right coronary artery here, and you've got this thrombus here in the artery, and this tight narrowing. Often the thrombus may or may not cause narrowing. Now you could have plaque rupture and the thrombus there, and actually not much of a narrowing, but just the little bits of blood clot that flick off down the artery are enough to cause the micro-injury and the troponin to go up. And then this is the magic of stenting. So you stick the stent in here, and it looks like a normal artery. Of course, it's not a normal artery because there's a stent in it, and that is not normal. But if that will re-endothelialize, and for practical senses, there's no restriction of the blood flow down the artery. Okay, so here's another case. So 21-year-old. So you immediately think 21-year-old. Probably not coronary disease. Do see it occasionally, but that's the first thing. So he's fit and well. He gets, but statistically unlikely. So he gets continuous left-sided chest pain in the lower chest. So the fact that it's continuous, we don't know how long continuous is, but that's pretty unusual for coronary disease. Although if you've blocked an artery and it actually is going to continue potentially up for 12 to 18 hours until all the muscle is dead. So it could be continuous in that sense. So it's worse with breathing, so that suggests chest wall or pleuritic cause. He's fatigued, he feels mildly short of breath. I told you to worry about shortness of breath. He developed the symptoms a few days ago, and the ED just gave him some paracetamol, and then he had a bit of a respiratory infection. And then he's got an ECG that looks like this. Does anybody want to say what this is? Yeah, so this is pericarditis. So what you see here is there's ST elevation here, and it's actually, you see that ST segment, everybody see that? Now when you look at it, it's just in every single lead, and there's no Q waves, so there's no Q waves anywhere which so you get so the Q waves mean that there's muscle infarction, but obviously that doesn't exclude that it's coronary. But the fact that it's in every single lead, it means that the current of injury is from every direction you're looking at around the heart. So with pericarditis, the inflammation is right around the surface of the heart. So that's why you're seeing this ST elevation everywhere. So this change and this particular way that the ST segment goes is typical of pericarditis. And actually its history is very typical as well. So it's a more a discomfort's there for a while and change, easier if you lean forward, or big hurts when you take a big breath. You might hear a friction rub. If you listen, you may not. Certainly it would be very unusual in a 21-year-old to have an acute myocardial infarction. But if you saw just this ECG here, you'd think, gosh, there's ST segment there, is this ST elevation myocardial infarction. But then when you look in the other leads, you see it everywhere else. Then that's what do you expect with pericarditis?
I had a patient with pericarditis with normal ECG, and it actually only diagnosed it because the registrar by mistake had ordered an echo for this patient, and then it discovered on echo.
Right. Yes. Yeah. So it's certainly plausible, quite possible you actually miss the diagnosis if the ECG is normal. And the thing about the troponins. We do find the troponins up a bit sometimes in pericarditis, and it's almost certainly because you often get a myopericarditis, so they're both together. And the myocarditis bit of it actually can be associated with short-term risk because there's inflammation in the myocardium. So we do measure the troponins, and if they're up, I think we've got to warn patients that there is some short-term risk of arrhythmias, and they depending on what they are, would observe them, or certainly avoid vigorous exercise and things until they return to normal. So here's another patient. So previously well 50-year-old man, he gets sudden onset of severe chest pain when he's cycling. So and it radiates to the back, and the blood pressure is 140. His heart rate's high at 110, and when you listen to his heart, you hear a 2 out of 4 early diastolic murmur. So you can actually make the diagnosis from that information, but what do people think about that? So the first, there's a diagnosis. So the first thing is the pain radiating through to the back would be, this is an aortic dissection. So so it's a tearing between the layers of the wall of the artery. So it often presents as a sudden, very severe pain, but the pain tracks in the direction of the tear. So if it's in the ascending aorta, it can start anteriorly, and then as it tracks around the aorta, it goes through to the back, and then you can sometimes get these incredible descriptions that it started here and it went through to the back and then it went all the way down there to my legs, and you just that's where the tear goes. So discomfort that starts in the anterior chest and goes through the back, you at least need to think about dissection. The thing about dissection is the ECG might be normal and the troponins might be normal, so you're relying on the history, and then if there's any suspicion, you get a CT scan. And then the auscultation, well, the heart rate being up could be just because he's got a severe pain, which is very bad, and the blood pressure is, well, that could be up because it's actually a slightly wide pulse pressure there, which is probably due to the EDM. So in this case, the dissection involves the aortic root, and then that disrupts the aortic valve, and then the blood leaks back into the ventricle. So that's why the pulse pressures, the diastolic pressures lower than what you'd expect for a heart rate like that. So then well, I'll get to that. So here's, I assume it's this patient. Now this is a CT scan, and this is the ascending aorta here, and you can see these lines of a tear within the intimal media in the ascending aorta. And the key thing is if there's, well, this is a medical emergency. There's a mortality of about 10% an hour if it's in the ascending aorta, and so as soon as the diagnosis is made, it's straight to the operating theatre. Well, as soon as you get to the operating theatre, to replace the aortic root. And then this is the aortic regurgitation seen with an echo or a Doppler, so that you get the stream of blood leaking back into the.
He's a pretty young guy for a dissection.
He is, yeah. Well, in this case, no, but you're right. So that the young people with dissection, you think of Marfan syndrome or Ehlers-Danlos syndrome. So probably maybe 30 to 40% of people who have dissections do have it genetically or inherited predisposition. And with Marfan's, this is the major cause of death. And the reason why most, the Marfan's patients, you'll do imaging of the aorta or serial imaging of the aorta, and if the aortic dimensions increase, they would have a prophylactic operation, so they have an elective operation to
Should people like that do things like cycling, high intensity cycling?
Well, the good question. If you know you've got the risk, then probably the risk is probably higher when you're doing vigorous exercise. In absolute terms, well, that's a good question. But generally, you do. If you think somebody's at risk, you would suggest that they should avoid vigorous exercise. And you certainly have a lower risk, a much lower threshold than normal for antihypertensive medication if they've got a disease which is going to be triggered by stress forces within the aorta. So this is just, I say this because it's a relatively, it's not such a common thing, I guess, that you'll see, but when you do see it, you don't want to miss it, and it is a medical emergency. So there's two types, in simple terms, there's two types of, there's dissection, it's just this. Well, we think of it in two sorts of dissection. There's one is in the involving the ascending aorta, which is potentially life-threatening because you can tear into the coronary arteries, you can rupture back into the pericardial space, which usually causes tamponade and death straight away, or you can get severe aortic regurgitation, and you can shear off the head vessels, which might cause a stroke. The type B dissection typically occurs here at the below the left subclavian here, and that where the tear goes down here, and that's much less of a that's often managed medically, and may or may not need intervention, and if you do need intervention, it can sometimes often be dealt with by stent grafts. And this is just to show the aneurysm of the ascending aorta and the dissection, and then how that operates. So that, yeah, some of these risk factors for disease and, you know, connective tissue diseases, family history, hypertension, known aortic valve disease, so patients with bicuspid valves have a higher risk.